Hi everyone, welcome to this lecture on school-age children. It's Molly Lombardi, and if you have any questions at any time during these lectures, just give me an email and I will respond to them as soon as I can. Alright, so here's the outline for these lectures. I've divided it into two parts. The first voiceover is part 1, which you are in. We're going to go over growth and development, different assessment approaches for this age group, health promotion, and hospitalizations. Then in the second part, we'll go over the immunizations and communicable diseases. All right, the first section is growth, development, and the nursing assessment. As you can see, the assessment includes vital signs, intake and output, pain assessment, and a general survey. The child between age 6 to 12 will typically gain about 3 to 5 pounds a year, and they're going to grow in height typically 1.5 to 2.5 inches each year. The most important part for the nurse to do is to plot this information, so their height and weight, in the CDC chart. This chart helps identify where in the curve the child lays for their height and weight, and it's in percentiles. So if you have a child who's in the 5th percentile, it indicates that only 5% of children are smaller than them, and 95% of the children for their age group and sex are larger than them. In this growth chart, you can see that they will be going through a spurt, the growth spurt, and for girls, it's typically around age 10 to 12 years, and for boys, it's around 12 years of age. Another intervention for the nurse to do is to assess the BMI of the child. Just like in the previous lectures, there are developmental milestones too, and the theorists are listed below. The first developmental stage, according to Erickson, for this age group is industry versus inferiority. And typically you'll see a lot of rules being followed and forming social relationships, and it's extremely important at that age group. Next is Piaget's the concrete operational thought, and this is when the child will continue to be less self-centered than previously, and their thought process is more coherent and logical. So you'll see them starting to solve concrete problems, but they're still unable to think abstractly. According to Freud, the school-age child is in the latency stage, where they focus on peer relationships, and there's an emphasis on privacy and understanding the body and how it works. Finally, we have Kohlberg, and they're in the conventional stage, according to this one, where they seek conformity and loyalty. They typically, again, follow rules, and they maintain a social order. Vital signs. So now obtaining vital signs should start to get a little bit easier in this age group compared to the infants and especially the toddlers and preschool age, where it was difficult to obtain vitals because it was frightful for them. Now they're starting to be okay with it, but you still want to explain everything that you're doing to promote that cooperation. The chart of vital signs for age 6, 9, and 12 is taken from your textbook. And I want to highlight that on the pulse, it is going from a high 95 and gradually going down to 85, where it is a little bit closer to a typical adult assessment finding. Respiratory rate, same thing. It's slowly decreasing to reach closer to the adult rate. And the systolic and diastolic pressures are going up, again, to match those of an adult. So you'll see that a fever is classified as a temperature of 101.4 or greater. Sometimes people will say that their child has a fever when it's just 100, and that's not the case. It is also important to note and pass along in your education to parents that the fever itself will not cause a seizure. Rather, a febrile seizure occurs when there's a sudden increase in temperature. High fevers of 104 in an adult client will indicate that there is a severe infection, typically, whereas with children, it's common to have high fevers, and it's not always a serious sign, but rather because they have an immature immune system still. Now we're moving on to assessment of intake and output for this age group. So the slide might look a little overwhelming at first, but let's just go through it. First, the daily fluid requirements. So in pediatrics, we typically go through weight base, so that's why you see the mLs per kilo per day. If a child is 11 to 20 kilos, how you figure out their daily fluid intake is you automatically have 1,000 mLs, and then you're going to add 50 mLs for each kilo greater than 10 kilos. So an example is if you have a child who weighs 15 kilos, so right off the bat, you know that they're going to need 1,000 mLs for that day because they're over 10 kilos. Then you have an excess 5 kilos. So for each of those kilos after the 10 kilo, you're going to add 50 mLs. So you'll see I have the 1,000 mLs plus 50, 1, 2, 3, 4, 5 times, and that totals 1,250 mLs per day that child should have. If the child is greater than 20 kilos, their daily fluid requirement would start off with 1,500 mLs, and then you would add 20 mLs for each kilo above that 20. So an example is if the child is 30 kilos, you start off with 1,500 ml because they weigh more than 20 kilos, and then you add 20 mLs for the next 10 kilos. This would total 1,700 mLs per day. Finding out their daily fluid requirements is especially important when you're calculating maintenance IV fluid rates. On the other side of the screen, we have expected urine output. And for the younger school-age child, that's age 6 to 7, the expected output should be between 1 to 2 mLs per kilo per hour. So again, I have an example. If you have a 7-year-old child that weighs 22 kilograms, they're expected to have an estimated 22 to 24 mLs per hour, or 250 mLs to 1,056 mLs in 24 hours. The older school-age child, age 8 to 12, their expected urine output is 0.5 to 1 ml per kilo per hour. Again, an example, if you have a 10-year-old that weighs 33 kilos, you take the 33 kilos, multiply it by 0.5 to get the 15 mLs per hour on the lower end of the scale, where the upper end of the scale is the 1 ml per kilo, or 30 in this example, per hour, to get the 30 mLs. The daily, or over 24 hours, is the range of 360 to 720 for this example. All right, so now we're moving on to assessment of pain. So again, we have the Wong-Baker FACES scale, and this is great for the younger school-age child. Like any kind of scale that we use for any client, whether they're children or adults, it's extremely important to educate your client on how to use it effectively to make sure that everyone's on the same page. Sometimes the children will inappropriately score themselves just because maybe they're feeling sad and there's tears in number 10, when really their pain might only be at 2. So it's important to educate them that it's just on their ouchies or whatever is appropriate for your client to describe it as. As they start to get a little bit older, so middle school age, they'll begin to point and describe their pain. So maybe younger will just point, and then as they get more vocabulary, they can give you some descriptives, whether it's dull or sharp, continuous or intermittent, but of course their words might be all the time or sometimes there. The older school-age child will begin to shift over to the numeric pain scale of 1 to 10 that we use with our adult clients. And the older school-age child are able to describe it in even more detail about the pain. Now with the assessment, we're moving over to the general survey, and we're going to highlight items that are different for this age group. So to start off, one thing that is specific to pediatrics is assessing for child abuse. And because we are nurses, we are mandated reporters that need to hotline any suspicion that we have, any red flags. Our job is to simply identify that there's a possibility of child abuse or neglect and to hand it over to the appropriate authorities to further investigate it. So you would assess for any abnormal bruising, both location and different stages of bruising, any cigarette burns or anything, or when the story doesn't seem to match up to the clinical findings that you have in front of you. In addition to this, the good touch, bad touch talk should be going on to identify and prevent, hopefully, any sexual abuse. So on from head to toe, because hopefully at this age group we can do a good head to toe assessment. The assessment of a head of a school-age child also includes assessing for any head lice, which are small insects that live on the scalp, and typically you won't see the bugs themselves as much as you'll see their eggs or nits that are attached to the bottom of the hair follicle. In addition to that lovely topic, the assessment should include any signs and symptoms of recent trauma, such as headache or the inability to concentrate, any recent loss of consciousness. On to eyes, the typical screenings for this age group include visual acuity, or the Snellen chart that you'll see with the E on the top of the picture and go down to assess their both near and distant sight. Then you will see the color blindness test that's in the top right of your screen. This is called the Ishihara test. Below that picture, you will see the little girl having her hearing tested to assess for any hearing loss. Common with school-age children, there's also typically buildup of wax or even fluid in the ears that can affect hearing. So this should be assessed in addition to their hearing test. On to mouth and teeth. Commonly, we have the loss of primary teeth, and by the end of the school age, they should have their adult teeth. So during this time frame, it's common to have orthodontic work, and we're going to continue with the every 6-month dentist checkup and cleanings. Still with the general survey assessment, we're just on further down the body, onto the nose, assessing for any allergies and inflammation related to that of the nares and nasal passage. In addition to assessing for frequency of nosebleeds, this is a common problem for this age group due to nose picking. Now on to cardiac. Assessment will focus in on any congenital abnormalities and any innocent heart murmurs, and they're called innocent heart murmurs because they're very common for children to have them, and they usually self-resolve without any treatment. The respiratory assessment should include any history of asthma, which is a very common health condition for children. GI and GU, any bedwetting, also called enuresis. Then for GU, there's also encopresis, which is when children will hold their bowels and not have a bowel movement. And sometimes this is due to their developmental stage where they view bowels as a part of their body and they don't want to let it go. Or it could be a power struggle with their parents, and it results in the child having constipation and very hard and painful bowel movements when they finally do release. The reproductive assessment at this age group will include Tanner staging, and we will go over this more in the adolescent lecture. Towards the end of this age group, so age 12, some girls are going to start to have their first menstrual cycle or menarche, which we will go over in greater detail in the adolescent lecture as well. Precocious puberty is when they go through puberty age younger than 7 for girls and 9 for boys. Neuromuscular and musculoskeletal assessment, they will have an increased motor and coordination compared to that of the early school age or the preschooler. So you'll see a lot more of sports and gaming than you would in the younger ages. Still on the general survey assessment, I want you all to remember that the developmental stage of the school-age child is really important. You will see the children start to move away from home as their primary source of support and start to lean more on their peers and friends for that support and guidance. They will start to join these clubs and groups. They'll start to have best friends, and it's really a time where you can help guide them through their social interactions. The development of consequences and the internalization of values takes place in the middle childhood years. And there are different theorists with variations to the stage, but overall, know that children begin to understand that there are reasons for the rules, and they have feelings of pride or guilt associated with their decisions and actions. This is a very impersonable age where they may be experimenting with cheating, lying, or stealing. And a child at this age is learning their self-discipline, and they want to expect discipline for their wrongdoings. So needless to say, they're able to understand and obey the rules. Additionally, they love to have collections, whether it's stamps or coins or Shopkins, what have you. It's common for this age group. These next two slides are not from your textbook, but I do feel that they're important to mention for this age group. The assessment here is focusing on the somatic complaints and sources of stress for school-aged children. So know that somatic complaints are complaints that are not verified with data that you can obtain. So nothing measured, but rather they might complain of headaches or belly aches. And sometimes this is due to any school or home problems that may be going on, anxiety, stress, or depression. So on the slide, you'll see a bunch of sources that they're exposed to that are stress. And in our society lately, we've been having some changes where the children are exposed to more stressors, specifically at school. We're extremely competitive with our sports, which lead to fear of failure, especially in front of a crowd. Commonly, they will experience tight schedules, and this is due to working families or single-parent families, which make it difficult for scheduling extracurricular activities and causing this constant rushing. There's family pressure for overhearing either parental stressors, and this can produce anxiety and fear in children. Influence of the media, and media I also include in here gaming, which can be violent and many times sexual, causing stress and confusion of this age group when they not fully understand this content. Not only should screen time have quantity limits, but there should also be limits set on the content. Violent subject matter has been shown to desensitize children, leading to more violent behavior in them. The American Academy of Pediatrics recommends that healthcare workers assess media exposure at every well visit and encourage parents to support and recommend daily limits of screen time. And finally, chaotic living conditions. And this is when the children at this age still find comfort in uniformity and routine and structure. So if there's chaotic living conditions, it can be a source of stress leading to somatic complaints. In addition of the somatic complaints, there are other manifestations of stress in children, including unhappiness or moodiness. So the children will not verbalize that they're experiencing overwhelming stress. Instead, it's common for the family to witness these unhappy moodiness episodes. They may see irritability or aggressive behavior. Often this is seen with close family members when there's an established sense of security. So this is when you will see the teacher saying that they're a saint and such a pleasure to have in class, and the parents are saying that they don't see this at home. The stress can interfere with sleeping, and this will cause fatigue and the inability to concentrate at school, leading to learning difficulties. Children could complain of, again, nausea and headaches or stomach aches, which sometimes are severe enough where the child will be hospitalized, and a bunch of medical workups and different procedures will be done looking for an organic cause. There's bedwetting and substance abuse and even suicidal behavior, which is increasing in the rate of school-aged children, unfortunately. That concludes the portion for the general survey assessment, and now we're going to discuss different assessment approaches for this age group, including just a general overview and then specifically talking about medications and procedure approaches.
Assessing this age group, it is important to have different approach than you would for either infants or toddlers or adolescent. This age group is typically more cooperative with the procedures, but again, you still want to explain everything that you're doing. Remember that just because they hit age 6 doesn't mean they're suddenly in a different age group and you treat them differently. It's a continuum throughout the lifespan. So the younger school-age children, they will want their caregivers present just like you see in the preschool period. Where the older school-age children tend to start to want to be more independent and more private, like you see with adolescents, so they won't want to have their parents present during the assessments and certain typical interventions that you might do. Again, speak directly to the child. The parents still might help answer the questions or do some prompting, but you start to focus more attention just on the child during your assessments and your health histories. Again, provide rationales and explanations for all interventions. Your rationales can start to be more in depth because they have a better understanding of how the body works and the medical field in general. Still use rewards, whether it's verbal praise or stickers or treatment beads, whatever seems to be best for that child. If there is a painful procedure that is expected, it's best to save that preparation for immediately before, and this is to help decrease that stress and anxiety. An example is if a school-age child has to have a lumbar puncture, it would be extremely frightening to explain this to the child in great detail, and remember, we're honest with them, so to explain the pain that they're going to have, you don't want to do this, for an example, 2 days before it. You want to explain it right before it happens, enough time for them to process and understand what's going on, but not enough time for them to fixate on it. And we're still doing the most invasive and painful parts of the assessment and treatment last.
Assessment approaches for medication administration. So first I would love to point out, which you guys have all done your pediatric weight-based safe Medicaid, that the dosing is based on their kilos. It's milligram per kilos for any child less than 50 kilos and younger than 14 years of age. When administering oral medications, know that there's usually a variation of the form, whether it's liquid or pill form that you can crush. Remember that this age group likes to start to make decisions, so they should have a decision or a choice of whether they will have a liquid from an oral syringe or a med cup, followed by a chaser of either juice or water to help hide that taste. In addition to hiding the taste with a chaser, you can also decrease the taste of foul-tasting medications with cold foods prior, so maybe like an icy or a popsicle to help decrease those taste buds. Or you can mix it with flavored syrup, but still keep in mind that it's not okay to lie to the children and tell them that they're taking any candy. You still want to remain honest and let them know that they're taking medications, but you made it taste better for them. Parents can administer medications even when they're hospitalized, and they usually take it better for their parents, but know that you still need to supervise the administration for your documentation purposes and to ensure that the full dose was administered. If subcutaneous medications are to be administered, typically, EMLA can be applied to the skin, and this is going to numb the superficial area. So it just numbs the skin. It's not for the intramuscular route, and it's only if you have time to allow it to work. So you'll see in the pictures that I have on the top of the screen, the nurse will apply a glob of this lidocaine cream and then cover it with a Tegaderm and leave it on the skin typically for about an hour to up to 2 hours for the full effect of the numbing cream. Then when you have to do any subcutaneous injections or IVs, the child won't feel that pinch of the skin of the needle going in. If there's chronic subcutaneous administrations with school age, so an example is if they're diabetic, they may learn to administer it themselves, and of course it has to be under direct supervision of an adult. If an IV is necessary for this age group, the nurse should pay special attention to the location, and in addition to starting with the peripheral and going up, The nurse should pay attention to which dominant hand the child is, and if it's feasible, to go to the non-dominant hand for their IV location. Distraction is great to use with this age group during the IV insertion. So in combination with the EMLA and distractions, sometimes the children don't even feel the IV insertion at all. And then once the IV is in place, it is important to cover it with either Coban or Coflex. That's the image of the purple wrapping around it. It's a self-cling that helps the children not look at and fixate on the IV that's in their skin, because it can be quite disturbing for this age group. Additionally, the wrapping helps protect the IV a little bit, so they're still able to play and move around as they normally would without as much fear of pulling the IV out unintentionally. We're moving right along to health promotion with safety, nutrition and exercise, school and bullying, and substance abuse and sexual activity of the school-age child. Safety. So remember earlier in this lecture where I said the children are starting to gain more muscle control and coordination. They're really becoming involved in sports and activities, and subsequently there is an increase in accidents, especially these head injuries from sports and activities. There's been great emphasis in the schools, in the local community in this area, about concussion prevention and education for their coaches to recognize and remove the child from sports if there are any head injuries noted. Bikes, scooters, skateboards, and other sports, they should have helmets and protective equipment available, including the knee pads and shoulder pads and so on. Pedestrian safety, so they're starting to have a little bit more independence at this age group, and parents may not always be at their side. A lot of children will walk to school with another friend or a group of friends. It's important for them to know the rules of the road and to stay safe. This age group is typically very fearless and adrenaline seeking, so they are huge risk takers, and they don't understand the repercussions of their actions. Now on to nutrition and exercise. The school-age child has a decrease in caloric need at this age, so nursing education can include this information and let parents know that it's okay they're not eating as much as they did in the last stage. There is an obesity epidemic in the United States. So part of Healthy People 2020 action is to prevent obesity in school-aged children and adolescents. Nursing can help this by providing education to parents with a focus on them modeling healthy eating and exercise habits. Encourage fun and physical family activities together, and praise healthy food and activity choices that the child will make. Another nursing intervention that will help combat childhood obesity is to encourage participation in school activities and physical education times.
School and bullying. School was mentioned earlier in this voiceover as part of a reason for stress that you see in this child. It is probably the most common source of stress, and especially how the structure of school is changing and more demand is placed on younger children. Avoidance, refusal, or even phobia about going to school, it requires a more in-depth approach from an interdisciplinary team, including either teachers, counselors, parents, and even healthcare providers to come up with a plan and solve this problem, because the children will need school. Sometimes in severe cases, the solution to this is homeschooling. Bullying is a form of harassment. It is any unwanted attention, and it's usually negative. It causes the person who's being bullied to have fear and a feeling of powerlessness over the person who is causing that harm and the bullying. It's most prevalent in this school-age period, unfortunately. The nurse's role when dealing with school and bullying is to assess physical and physiological signs of bullying. It's also helping parents finding resources to assist with bullying, whether it's the bully or the one being bullied. Another role is to assist children with special needs and to make sure that they have the appropriate resources and support needed for them. Bullying and coming up with solutions to prevent and treat bullying, it's not just the child's role. It is a system, it's a group of people that need to work together and form this safeguard of their own circle. I did include a link here. It's a PBS video. It is about a half hour long, but if you have some extra time and this particular subject interests you, you can feel free to watch this video.
The nurse's role for substance abuse includes assessing and discouraging any alcohol, tobacco, vaping, or drugs being done, especially in the school-age child. It is also important to know, while it's up to the nurse to assess and discourage, that the parents have the strongest influence on this age group when it comes to alcohol and drugs. Sexual activity is also up to the nurse to assess the understanding and knowledge of sex. So this is when the parents are not in the room, obviously, so that way they're more open to the nurse in discussing these things. This is the age group when sex education starts in the schools. The nurse can assess if parents have started this education at home or not. Many parents find it difficult to start this communication about sex and bodies. You can help parents by providing additional resources and opening that line of communication and starting that sex education in the schools. A problem that is common with this age group, especially the older school-age child, is sexting, which is sexual explicit texting. Older school-age children who participate in sexting have an increased risk of risky sexual behavior in their adolescent years. We are almost done. This is the final section on hospitalizations. First, we're going to discuss emergency, then acute care, and follow up with chronically ill hospitalized child. Emergency care. So remember earlier when I talked about injuries, the unintentional injuries are the leading cause of death for children age 5 to 14 years of age. In a crisis or emergency, the healthcare provider is going to focus all of their attention on the direct care and stabilization and treatment of the child. The child life specialist, social worker, or chaplain will focus their attention and energy on the family unit. Family-centered care still is priority, even though it's emergency care. And the nurse is going to blend between stabilizing and treating the child and also caring to the family unit. The image on your screen is that of a child life specialist. They have a unique role in the hospital setting to make life as normal as possible for that child. So they incorporate their normalcy within their hospital, whether it's doing homework or activities such as coloring, crafts and arts, gaming for teenagers. So they try to bring childhood into the hospital. Acute care of the hospitalized school-age child. Parents still should be active and participants in the child's care and activities of daily living when hospitalized. The nurse can increase their comfort of a hospitalized child by allowing items and encouraging items from home to be brought in, such as blankets. Ideally, the nurse would want to encourage normalcy within the family, and this can be done in simple measures such as allowing them to go on walks as long as it's medically appropriate, off the unit to maybe the cafeteria and have some alone family time, to have private time within the room itself. If it's a semi-private room, hopefully there are play areas and parent meeting areas. Admitting siblings. So if you have a set of siblings who are admitted to the hospital, it's imperative to pair them up in a semi-private room together. This increases their comfort and also allows the family to visit one room rather than two different rooms or even two different units. Again, think of the developmental age of the child. They will love to make choices at this developmental age. So allowing them to make appropriate choices within their care will help them be an active member of their care and even excited about it. Again, be honest with them. Don't lie about treatments that you have to do. While being honest with them, it's appropriate to also answer questions to their developmental age. So don't go into medical jargon, obviously, but answer in a way that they can hopefully understand. On the right-hand side of the screen, you will see a Pew scale, a pediatric early warning system. This is actively used in inpatient setting, and it provides a numerical scale as to how the child is doing with an illness. So the components on the screen are cardiovascular, respiratory, and behavior. It's similar to the APGAR scoring that you'll use with a newborn. Except with the Pew scoring, you want your score to be as low as possible. You want all zeros. If you have zeros, it means cardiovascular is working, so you will assess for pink or capillary refill within 1 to 2 seconds. Their respiratory function will be within normal parameters, so that's back to the vital signs chart in the beginning of this lecture, and they'll be free from any retractions. Their behavior will be playing and appropriate, so that will give the child a 0 for their Pew score. Where on the other side of the spectrum, their cardiovascular, if you assess for gray and molted or capillary refill greater than 5 seconds, that's bad and it's going to get them a score of 3 just for cardiovascular. For respiratory, if they are 5 breaths per minute below their normal respiratory rate, or if they have grunting, or if they're on oxygen greater than 8 liters per minute of 50% of high flow, that will give them a 3. For behavior, if they are lethargic or confused, or if they have a reduced response to pain, that will also get them a score of 3, totaling a score of 9. I encourage you all to take a closer look at the Pew scoring system in your textbook. Finally, we have care of the school-age child who is chronically ill. Typically speaking, the parents of a child with a chronic illness is very active in their care and extremely knowledgeable about their condition. The family-centered care is paramount because the parents become the experts. With a child who has a chronic illness, it's common for the parents to experience caregiver fatigue, where it's exactly what it sounds like. They have a lot of responsibilities and constant care that they provide to their child, and they can easily become fatigued or burnt out. Respite care can be provided and often done in an inpatient setting where the child will be hospitalized and the nurses will care for the child while the family takes a momentary break. It's important to remain non-judgmental when you have a child of respite care, and rather to be supportive and understanding of the family situation. The school nurse plays a huge role in the chronically ill child. They provide daily medications. Sometimes the child will have a one-to-one nurse, meaning that when they're in school, they have a nurse assigned just to them. Other common interventions for the school nurse with a chronically ill child include straight catheterizations, tube feedings, seizure management. The school nurse will coordinate with the parents and also some school officials to compose an individualized plan of care for that child. That concludes part 1 of the school age lecture. Continue over to part 2 where we will go over the immunizations and communicable diseases. If you have any questions at all, please don't hesitate to email me.